So metabolic management and heart failure, how important is its place in the current algorithm of heart failure management, sir?
I personally think that metabolic management per se is extremely important, both in the management of heart failure and in ischemic heart disease. After all, what is the final terminal point in ischemia? It is the cellular ischemia which is important. And the metabolism of the cell is what really produces both the ischemia and eventually leading to heart failure. Especially in heart failure, we know that there are a large number of drugs available for the treatment of heart failure. They are approved, they are randomized large studies which show clearly benefit, like AC inhibitors or ARBs, beta blockers. However, metabolic drugs like Trimetazidine and Ranolazine have been found to be useful both in coronary artery disease and ischemic heart disease. Trimetazidine particularly has been shown to improve left ventricular function, to reduce cardiac events post PCI, post bypass surgery, and certainly improves the quality of life of patients with heart failure. There are small trials, one small prospective trial and one larger retrospective trial, which shows that even mortality benefit is there with the use of Trimetazidine.
So when they should be added in the management, early in the disease, or there is some specific point in the disease spectrum when they should be added?
The problem with metabolic drugs is that some believe that they don't work at all and don't use it at all. I think that they're extremely useful. The others who do use it also often tend to use it rather late in the disease, when the disease becomes terminal. I think it's very important to start early. I'm not suggesting that metabolic drugs should be the only therapy, of course not. All the guideline drugs should be started, but I think a metabolic drug should be given in addition to the guideline drugs. The big advantage of metabolic drugs is that it doesn't produce hemodynamic changes. So you don't have to worry about fall in blood pressure, which is a big problem with heart failure. You don't have to worry about heart rate changes, which is another problem. So I think you have a very good drug, clear benefits, very little side effect, and we should take advantage of that.
Is there any specific subset in which we should avoid these drugs, or they could be used in all the patients?
They could be used in all the patients. One side effect which has been noticed in the past is something like Parkinsonian-like symptoms, and maybe in those sort of patients one may want to avoid it. But there was a large registry follow-up, and it was found that really it was not a big issue. But clearly, except for that particular issue about Parkinsonian-like syndrome, it is very little side effects and can safely be used in the full spectrum of stable angina, ACS, post-myocardial infarction, post-PCI, post-CABG, and of course with heart failure.
So you said there are some trials are already available. So is there a scope of generating more data so that we can re-establish, or probably the guidelines may also adapt these agents?
Yes, I think one of the biggest problems and one of the reasons why guidelines haven't accepted this therapy as a proper high indication is that there are few or no real large-scale, big randomized double-blind trials. Yes, there are multiple small trials. In fact, there are plenty of small trials, but no single very large multi-center, multinational trial. So I think what we really need for a metabolic drug is one big, large, randomized placebo-controlled trial to clearly get it into the guideline therapy.
So your key two takeaway messages for the physicians or doctors who see heart failure patients but are still not using these drugs. So what will be our message to them?
My message is to doctors for management of heart failure is that one, metabolic drugs are very useful. They will reduce the patient's symptoms. They'll improve the ejection fraction. There's a trial which actually shows a reduction of even restenosis because of the inflammatory benefits of these metabolic drugs. So I think use them early, use them in all your patients, and see how the patients will benefit.
Thank you, sir. Thanks a lot for joining us today. Thank you, sir.
I personally think that metabolic management per se is extremely important, both in the management of heart failure and in ischemic heart disease. After all, what